There may be some repetition, but I do want to dig a little bit more deeply into some of this. So for one thing, we know that this data is almost a year old that's contemplated in the report, but we also know that things do not seem to be improving. As of September 10th of this year, the average ER offload time was 110 minutes. That's way above the 30-minute target. And that obscures the very long wait times that are above average. And many of our hospitals here experience that. So 155 minutes at the Cobequid Community Health Center, 170 minutes at the Dartmouth General Hospital, and 195 minutes over 3 hours at the QE2 Health Sciences Center, to which so many people are brought in such critical condition. We had a similar committee meeting 5 or 6 years ago when we were in fact permitted, per our motion, to bring the paramedics union. And when the question was put to them, you know, what does this mean? And it's not just the offload times, it's the response times, which we'll get to. He said it means people die. And that has always stuck with me throughout my career. It means people die. And so I do want to thank everyone here. As Ms. Oldfield said, I know that you all spend your time trying to fix this problem, but it's been over 2 years. The promise was a fix for healthcare, and we haven't seen these times move significantly. I think we heard 10 minutes. I would like to see that average extrapolated amongst these different sites that I've mentioned. When are we going to meet the targets? When are we going to get to a place where we don't need to be concerned that, you know, Nova Scotians' health and lives will be impacted by these wait times that are so far off the target of what is acceptable?
Mr. Beaton?
Thanks very much. And I can assure you that the weight of people waiting for ambulances weighs on all of us deeply across this table, which is why we've put a number of initiatives in place to try to address that. I would say that this has been building for a number of years, so it's going to take us some time to sort of get out of where we are, and I think we have been showing signs of making progress towards that. You've mentioned, you know, an average time of 115 minutes. We do know that in 4 regional sites, the times have gone down over the last, 8 months since January. So, as I mentioned, the Auditor General's report, the data collected is up until December of 2022. We monitor that data on a daily basis with Mr. Fraser and his team. They're very deep into the analytics, as well as in conjunction with Mr. Murphy, who's also here representing or with us from Department of, Nova Scotia Health. Response times, absolutely a concern as well. We have seen a reduction in the last number of months too. Now, albeit it's only a few minutes, but it does show a signal in the right direction from 28 minutes down to 25 in terms of average response time across the system. But I do highlight that we've done some jurisdictional review across the system as well, and across Canada, the typical average offload time in terms of what they monitor in terms of a standard is about 45 minutes. Our standard is a little bit more aggressive. I can tell you that no jurisdiction is meeting their standard because of the reasons that we talked about before, which is a human resource issue. There's a significant human resource issue in paramedicine across the country. So as Mr. Daniel had talked about, there's a number of initiatives underway to try to retain, but also on the recruitment side, we're looking heavily. I do know that EMC has actually either just come back or they were in market actually in Australia looking to recruit paramedics, working collectively with our college around how we modify entry requirements and scope. So I guess in closing, I would say that we are tracking in the right direction, but it's not, there's no silver bullet. There's a number of initiatives that we have instituted that I think are making progress. So I would just highlight one in particular, which is trying to divert ambulances from actually coming into the emergency room. So we have the single paramedic response units. Those didn't exist 2 years ago. We have them now in place, and they're active mostly in Central Zone. Obviously, we're looking to expand that. And just to give you an anecdote about the duration of how many people that diverts from an ED, there's roughly about 6,000 average visits to the QE2 per month. And the SPEAR units are diverting about 500 per month, which, if you average that out over a year, that's a whole month's worth of ED visits diverted through this single response unit, which is actually treating people in the community. So,
thank you, Mr. Beaton. Ms. Chender.
Yeah, there's a lot. There's a lot in there. I think you mentioned the times. So I would be remiss if I didn't note that offload times, our target was 20 minutes, and then it moved to 30 minutes without much discussion. And while I appreciate that those times aren't being met across the country, I would say we have some unique barriers here that could be alleviated. Again, I want to note that we're not hearing from paramedics in this conversation. Their voice is invaluable here because they can speak to what's on the ground. So I'm certainly hopeful that they will. I know that Mr. Fraser was a paramedic. He's not currently in the field, and he is in a management position at Health and Wellness. So with respect, I don't think that counts in the context of this conversation.
Ms. Chender, I'm sorry, we have a point of order here from Mr. Taggart.
Thank you, Chair. In the previous preamble, and again here we refer to paramedics, and I truly appreciate paramedics, but it was said that 5 or 6 years ago, paramedics were before this Public Accounts Committee, and so I'd like to have that tabled if I could, please.
Mr. Taggart, I'm going to add another minute onto the NDP time. Ms. Chender, Ms. Chender. Sorry, no, Ms. Chender.
Thank you very much. Anyone can look through Hansard and find the record of that.
Do that during your time.
Sorry, just to get back to where we are. So we do have some unique challenges here, and ones that I think could be addressed. And so, what the main one, I'm glad that we have paramedics in market, that we have, people in market in Australia, but we are bleeding paramedics here, and one of the reasons is compensation. We have the lowest compensation. Glad to hear that there's a contract coming, but there are many things that we hear from paramedics that could be done. We hear that they don't actually feel supported in their health and wellness. We hear that they don't feel supported in their return to work. This is anecdotal, but these are a number of conversations across the province that we have, and so I will leave that with you since we don't have that voice in front of us. But I do want to just turn to responsibility. So I love that we have a team here and that, it's all hands on deck. But at the end of the day, my understanding is that the Nova Scotia Health Authority is ultimately responsible for offload times. Of course, that's via EMCI, who is the provider, but Nova Scotia Health Authority, in theory, manages that contract. And so, I know that the AG's report did suggest that the response recommendation 1.5 around managing that contract is insufficient. So I guess this is for the deputy. I want to ask Ms. Legacy, who is responsible for this? At the end of the day, where does the buck stop in terms of ensuring that we have accountability and we turn it around?
Thank you.
DM Lagacé.
Thank you for the question. So I think we've already had a bit of discussion about this, and Ms. Oldfield spoke to it a bit earlier, but as the Auditor General herself says in the report, the system is extremely large and complex. And as a team, and that's why there are so many people here today, we are working toward just solving the challenges and pressures that are within the system, including offload delays, which will then also lead to increases, hopefully, in response times. But in doing so, we have to look at all of those problems as a system. And we can't look at things in isolation and hope that a change in one area is going to be a change in the other. So from an accountability perspective, as Ms. Oldfield said, there are 3 of us here who are ultimately accountable for our organization. There is no question about that. But value that the health leadership team is bringing is we're trying to solve those problems as a system. And so the health leadership team is ultimately accountable to the minister, but we can't do it, my organization, Ms. Oldfield's organization, Ms. Poirier's organization individually. We have to do it together, and that's what we see the value in the health leadership team and that system accountability. There's, yes, individual organization accountability, but it's about the system, and that's why we're doing it together.
Ms. Chender.
Thank you. Okay. I want to move on in a minute to the human resources piece that we talked to, but before I do that, I just want to go to the ER closure question, because although we do have those urgent treatment centers, although they are playing a role, my understanding, and you could correct me if I'm wrong, Ms. Oldfield, is that they actually don't impact ambulance offload per se, because ambulances can't offload. And so in those centers, and this is what we hear from paramedics, right? Like, if we get a call in Middleton and Middleton is closed, then we might be driving to Kempville or we might be driving to Yarmouth. And if we're driving to Yarmouth, that's a real problem for everyone involved. It's a problem for the patient. It's a problem for us. It's probably a problem for Yarmouth down the road. How's the patient going to get home? Our understanding, based on the accountability report, was that emergency room closures doubled year over year last year. And the human impact of that, of course, is Nova Scotians in communities across the province who cannot access emergency care in an equitable way. And so my specific question is, when will those ER closure times improve, or can we just not expect to have emergency rooms in smaller communities in Nova Scotia?
Ms. Oldfield?
Thank you. I would never want to give up and say that will happen. So our job is to work as hard as we possibly can to recruit and to put the right skill sets in the best place possible. So I'm not going to throw in the towel on rural emergency departments. No. However, we have to do something, hence our urgent treatment centers are something. This, to a rural Nova Scotian, I would say, you've got to do more, Karen. You got to do it a lot faster. I hear this too every day. I talk to our staff, I talk to people. I've been around this province 3 times in 2 years, talking to stakeholders, to people, to staff. I hear the same things that you're hearing, and I don't sleep very well because I'm looking for the silver bullet. I'm looking for the needle in the haystack. It just doesn't exist. So, yes, we're recruiting. We're recruiting NPs, we're recruiting nurses, we're recruiting physicians. We're making strides there. We're creating seats. We're doing all of the things that Nova Scotians would hope and expect us to do to start to make strides on the human resources. We can't wave the magic wand, but we are making progress. We've created the new physician assistant program starting at Dalhousie University. We've in the midst of starting up a medical school at Cape Breton University. The list could go on, and I'm sure we'll have an opportunity through the session here today to discuss. But you're right. It's a challenge, but we can't just solve it with a snap. It takes a long time to produce a qualified healthcare professional. So we scour, we go where we need to go to bring people to this province. We can't do it fast enough.
7 minutes, Ms. Chender.
Thank you. Well, that's actually a great segue, because it does take a long time to produce a healthcare professional. It is much more inexpensive and effective and ultimately good for the province if we can keep the ones we have. And we have been bleeding paramedics for a long time now. And so I guess one of the things that I want to get to is, why haven't we had more of a focus on retaining the paramedics that we have in this province. So, you know, paramedics were excluded from the MOST program expansion that this government kind of put out at the beginning of their mandate. They didn't get those incentive bonuses to train in paramedicine, local Nova Scotians. They didn't receive the lauded raise that the CCAs received outside of collective bargaining. We can talk about whether or not that was a good thing or a bad thing, but it retained some CCAs who were in those positions. And their compensation has been stuck at the bottom. And what we hear from paramedics, and we've heard this for years, is we're the best trained and we're the lowest paid. And so people used to train here, get on a rig, because you could do that, and Jeff is nodding, Mr. Fraser, he knows this is true, and then they would leave. So they'd get the experience they needed, and they'd go to Ontario, or they would go to Alberta, or they would go to a place where they could make twice as much money with the experience that they got in Nova Scotia from our system, and that hasn't stopped. The only thing that has stopped is they don't stay to get on a rig anymore. And in some cases, they don't even sign up for the training. And so it's a dwindling pool, but we have paramedics here who are leaving in droves. And so my question is, what is the, you know, I'd like to hear the specific efforts at retention that are happening right now in terms of compensation, in terms of health support, because it's a very, very challenging workforce, and I have ethical concerns about bringing people here to do these jobs that people are burning out from day after day after day and expecting a different result, right? We can't do the same thing and expect a different result, and it feels a little bit like that's what we're doing in terms of workforce.
Mr. Daniel.
You go first.
Oh, Mr. Fraser.
Thank you for the question. I think to echo what Mr. Daniel had said earlier, it is a tough environment. To answer your question around retention, the department put together a committee about 2 years ago, really focusing on recruitment and retention initiatives. The first part of that thrust was about bringing people in. Well, we knew that we needed to try to get the union and the company to the table early, which we were successful in. Now that process has to unfold, and hopefully that we'll be able to address some of those issues through that process. That's just one part. The retention issue is, you know, and Mr. Daniel said it's a tough environment right now. And to be clear, I wouldn't want to represent that. To your point, is that I'm not in the field and not in the trucks anymore, but yet very well aware of the challenges that are out there. Nothing more frustrating to hear from a paramedic or to be one and to see the last ambulance in a community go for a call for a patient that may not necessarily need transport to the hospital that goes already to a busy hospital. Our focus in doing what we can do with the box we have to work with really is about improving the experience for the patients that we see and improving the workplace conditions for paramedics. And our focus has been on keeping people out of the emergency department that don't need to be there. And there are many things we need to do, but that's really been some of the focus. Some of those ideas, Ms. Chender, have come through EMC's Employee Advisory Council. To give you an example, the direct-to-chairs directive piece that the department helped EMC put in place was a result of that. Experienced paramedics seeing patients that believe that they can jump the queue, so to speak, by using the ambulance service to go to the emergency department, when really it's not an emergency visit they need an alternate care pathway. So our focus in the last year is trying to improve the workplace conditions by providing paramedics options that they can do with their patients versus just the traditional take people to the emergency department. Many things to do, but those two things, getting to the table early and trying to get an agreement, a tentative agreement that we can get ratified, and then focusing on what's in our control from the work environment. And so along with that come the supports in place for paramedics that weren't there before. We have a physician 24 hours a day, boots on in that center, that's there to help guide paramedics through some of these difficult decisions and conversations they have to have with families. The nurse program that we put in place is really more about creating capacity and giving a patient a better experience. We've only been up and running since November, and I understand people's patience, but there's been a lot of investment that now has been sunk. It's in place. Now we have to just see what's going to happen. Our non-critical care aircraft. I can tell you as a former operations director at EMC, when I would go to Sydney and Yarmouth, I would often hear about the paramedics and about how long they'd be out of their communities, how uncomfortable it was for their patients. This aircraft really, we've only had this in the air since the 7th of August. And from the 7th of August until the 30th of September, we've moved 132 patients and returned about 1,320 unit hours to create capacity in communities. Nothing's fast enough, and nothing's fast enough for me. But we just continue to push. So as we get these programs up and running, then we look at what else can we do to improve the patient and the paramedic experience, all the while improving the public safety piece.
Ms. Chender, 1 minute.
I only have 1 minute. What I did want to ask about, and maybe my colleague will pick up on this, or my colleagues in the opposition, is the contract with the MCI. So Nova Scotians feel like we have a public ambulance service, but we don't, actually. We contract a private company, and that's a $165 million contract, and my understanding is that no penalties have been paid regarding performance standards. I understand there are choke points, there's primary care issues. Nonetheless, we do contract to private companies, so I wonder whether there will be penalties. There was a recommendation from the AG's report, 1.3. The department says it's going to take another year. If someone could speak to that in, I don't know, 20 seconds and maybe pick it up after, that would be great.
Mr. Fraser?
Yeah, absolutely. So we're really looking at, we need an exemption process. Ms. Chender, I think we're trying to
Order?